I want you to imagine just for a second that you are trying to defuse a bomb.
Okay, high stakes right from the start.
Right, but the wires you need to navigate, they're microscopic, and they are woven intricately through this wet, highly vascular sponge.
That is quite the visual.
And the stakes of clipping the wrong wire here. If your scalpel strays by even a millimeter, a person loses the ability to smile forever.
Wow. Yeah, it is a staggering amount of pressure. And it's the literal, day-to-day reality for head and neck surgeons navigating the complex anatomy of the human face.
Welcome to today's deep dive. We are looking at a highly detailed, pretty dense set of clinical medical notes covering the parotid gland.
And salivary gland pathologies in general, yeah.
Exactly. Our mission here is to decode this medical shorthand to truly understand the high wire act of facial surgery.
Right.
We're going to explore how doctors diagnose, map out, and treat issues in an area where the margin for error is, essentially zero.
It really is. And, to even comprehend the stakes of the surgery, you have to understand the real estate involved.
Let's set the stage for the listener.
So the primary focus here is the parotid gland. It's the largest of our salivary glands. It sits just in front of and slightly below the ears on both sides of your face.
It is basically a massive saliva factory.
It is.
According to these clinical notes, our salivary glands pump out 1 to 1.5 liters of saliva every 24 hours.
Which is wild to think about.
Right, for visual context, that is an entire large soda bottle full of saliva being produced by your face every single day.
A tremendous and constant volume. And chemically, it's a finely tuned manufacturing process.
Like, it's not just water, right?
Well, it's mostly water. That fluid is 99.5% water, but it's balanced with sodium, potassium, and a highly specific pH ranging from 5.6 to 7.
But the real significance of the parotid gland, at least for a surgeon, isn't really the saliva itself.
No, not at all.
It's the structural layout.
Exactly. The anatomy is everything.
Right, because the all-important cranial nerve 7.
The facial nerve?
Yeah, the facial nerve, which controls your expressions, it runs directly through the center of the parotid gland.
Literally right through it.
The nerve divides the gland into two sections. You've got a superficial lobe, making up about 80% of the tissue, and a deep lobe, which is the remaining 20% back further inside.
The nerve doesn't just run alongside the gland, it pierces straight through the middle of it.
Just right in the crossfire.
Exactly. Anytime there is a disease or a growth inside the parotid, the facial nerve is essentially trapped inside the battlefield.
Before we get into those surgical life or death, bomb defusal scenarios, there are more common mechanical issues that happen when this saliva factory simply breaks down.
Yeah, the everyday plumbing problems.
The notes start with those.
Yeah.
And the most classic physical breakdown is a condition called silophiasis.
Which, in plain terms, means salivary stones.
Right, so kind of similar to kidney stones, but forming right in your jaw.
Yes, exactly.
The notes specify these are formed mainly of calcium phosphate, and the main symptom patients experience is highly specific.
It's intermittent swelling of the gland that happens almost exclusively when they try to eat a meal.
Which makes total mechanical sense when you think
It
about it.
does. You sit down to eat, and your brain sends a signal to the parotid gland to ramp up production.
The brain is basically yelling, turn on the faucets, food is coming.
Right, so the gland starts vigorously pumping out fluid.
But there's a roadblock.
Exactly, because there's a calcified stone blocking the exit duct, that sudden rush of water has nowhere to go.
Oh, wow.
So the pressure builds instantly behind the blockage, and the entire gland inflames and swells up right there at the dinner table.
Sometimes the swelling isn't a physical blockage at all, though. The clinical notes mention a condition called pseudoparotidmegaly.
That's a mouthful.
It is. But breaking down the Latin roots there, pseudo means false, parotid is the gland, and megaly means giant or enlarged.
So false parotid enlargement.
Exactly. The gland swells up, but there is no stone and there is no tumor.
Right, in that case, the gland is reacting to broader systemic metabolic issues.
Like what kind of issues?
Things like diabetes, severe hypothyroidism, or chronic alcohol use. The parotid acts as a sort of sentinel for the rest of the body.
Meaning it's like a warning light.
Pretty much. When systemic blood sugar or metabolic levels go completely out of balance, the localized tissue in the jaw reacts by swelling.
It's fascinating that a localized plumbing system reflects your whole body chemistry.
It really is interconnected.
The notes also detail how the gland reacts to autoimmune diseases, specifically Sjogren's syndrome.
Yeah, Sjogren's syndrome is an aggressive autoimmune condition. It's where the body's immune system mistakenly identifies its own moisture-producing glands as enemy invaders.
So it attacks them,
It primarily attacks and destroys the salivary glands and the lacrimal glands, which produce tears,
resulting in severe chronic dry eyes and dry mouth.
which is miserable for the patient.
To diagnose this, the notes outline some very specific tests. One is a labial mucosal biopsy,
Right, where doctors take a tiny piece of tissue from the inner lip.
just to check the minor salivary glands for physical damage. And for the eyes, they use something called a Rose-Bengal stain.
The Rose-Bengal stain is it's a brilliant diagnostic tool.
How does it work?
It is an ocular dye, but it doesn't just change the color of the eye randomly. The dye specifically binds to dead, damaged, or starving cells.
Oh, that's clever.
Yeah, so when a patient with Sjogren's lacks tears, the friction and dryness literally ravage the surface of the eye.
So they're just blinking and causing damage.
Exactly. The dye illuminates that physical graveyard of cells, showing the true extent of the destruction.
And the chronic destruction happening in Sjogren's comes with a terrifying secondary warning in medical notes.
Yeah, this is crucial.
Patients dealing with this syndrome carry a very real, elevated risk of developing B-cell lymphoma.
It is a severe escalation.
Huge jump, yeah.
Because the immune system is locked in a state of chronic, severe inflammation against the glands, over time, that constant biological warfare can actually cause the immune cells,
The B-cells.
right, the B cells to mutate into a localized cancer.
You go to the doctor because your eyes are scratching, your mouth is dry, and suddenly you're being closely monitored for lymphoma.
It's a heavy realization.
It really highlights how these superficial symptoms can hide massive biological threats.
Absolutely.
But as dangerous as that immune dysfunction is, the most intense reality in these clinical notes revolves around physical, structural growths. Tumors.
Right, and the vast majority of parotid tumors are technically benign.
But benign, in the context of the parotid gland, absolutely does not mean safe.
No, not at all.
The most common intruder is the pleomorphic adenoma, or PA, which makes up about 80% of benign parotid tumors.
And coming in second, at about 5 to 10%, is Warthin's tumor.
And the notes point out a major demographic quirk with Warthin's, which I found so interesting.
Oh, the gender difference.
Yeah. In the world of salivary gland tumors, statistically, almost all of them are far more common in female patients.
Right.
But Warthin's tumor is the stark exception. It is overwhelmingly found in older males.
It is a classic demographic anomaly, and it connects deeply to environmental factors.
Like what?
Well, while the notes focus on the clinical demographics, that specific male dominance historically ties directly to heavy rates of smoking in older male populations.
Ah, I see.
Yeah, smoking is a massive trigger for this specific type of cellular growth.
Now, regarding that term benign,
Let's get into that.
if a pleomorphic adenoma is benign, meaning it isn't aggressively invading other tissues or spreading to the bloodstream, it seems counterintuitive to perform a high-risk surgery.
It does seem that way.
Why aggressively operate and risk paralyzing the patient's face? Why not just leave it alone?
The sources provide two compelling, honestly non-negotiable reasons why a surgeon cannot just leave a pleomorphic adenoma in the neck.
Okay.
The first is the ticking clock of malignant transformation.
So it's benign today.
Today, yes. But the notes state there is a 1 to 5% risk of those cells mutating into a malignancy over a 10-year period.
And if you leave it for 15 years, that risk doubles to 10%.
Yeah.
The patient is essentially carrying a slowly arming time bomb.
Precisely. The longer it stays, the more dangerous it becomes.
Well, the second reason
involves the physical architecture of the tumor itself. It has an outer shell, a capsule.
Okay.
If that tumor is left untreated and eventually ruptures on its own, or
And this sounds like a surgical nightmare.
it is. If the surgeon accidentally nicks and breaches that capsule during removal, it causes something called tumor spillage.
Tumor spillage. I was trying to visualize this while reading. It sounds almost like a dandelion that has gone to seed.
That's a perfect analogy.
You blow on it
If you pop that capsule, microscopic tumor cells spill out and scatter into the wet vascular tissue of the surrounding parotid bed.
And they just take root.
They immediately take root.
So instead of dealing with one solid lump, the patient returns a few years later with dozens of tiny individual tumors scattered throughout the delicate nerves of their neck.
Which is exponentially harder to treat. The notes call these multicentric recurrences.
And they mention that by the time a patient faces a third recurrence, the anatomy is usually so compromised that surgeons have to abandon the scalpel entirely.
Yeah, they have to rely on radiation therapy at that point.
Just to control a disease that started out as completely benign.
It's tragic. And because rupturing even a benign tumor has such devastating consequences, and missing a malignant tumor is fatal, doctors cannot just cut into the neck blindly to see what they're dealing with.
They can't just go exploring.
No, they have to map the territory meticulously before they ever make an incision.
They have to act as detectives looking for clinical red flags.
Exactly.
Pain is a major indicator, right? Because benign tumors are typically painless.
Pain is a big one. Rapid growth is another.
And facial palsy, which means the tumor has grown so aggressive, it is actually invading and paralyzing the facial nerve.
Skin ulceration is another red flag where it physically breaks through the outer skin.
That sounds horrific.
And fixity, meaning the lump doesn't move when pressed. It feels cemented to the underlying bone or muscle.
The location also dictates some bizarre presentations. Remember the deep lobe of the parotid, that 20% tucked far behind the jawline.
Oh, right, the physical space there.
The space is so physically constrained by bone that a massive tumor has nowhere to grow outward.
It hits a wall,
It has to grow inward. The notes mention that a deep lobe tumor can present as an oropharyngeal bulge.
which is hard to even picture.
It literally displaces the patient's tonsil, pushing it immediately into their throat.
Oh.
A patient could open their mouth, say ah at the dentist, and just see a parotid tumor shoving their tonsil sideways.
That would definitely raise an alarm. So to figure out exactly what kind of cells they're dealing with, the initial investigation is an FNAC.
Ultrasound-guided fine needle aspiration cytology.
That's the one.
I actually had a question about the mechanics of this when we were going through the sources.
Sure.
The notes specify using a tiny 23 to 25 gauge needle for the FNAC. That is basically the thickness of a standard vaccine needle.
Very, very thin.
Right. But if doctors urgently need to know if a mass is cancerous, why not use a larger core biopsy needle right out of the gate to get a definitive solid chunk of tissue?
It comes right back to the dandelion effect we were just talking about and the danger of tumor spillage.
Oh, because of the hole it makes.
Yes, if you plunge a large 14-gauge core needle deep into a salivary gland tumor, grab a chunk of tissue and drag it back out, you are creating a massive open tunnel.
Ah. So as you pull the needle backward, you are potentially dragging live cancer cells through completely healthy layers of tissue.
You are actively seeding the needle tract with the disease.
That makes so much sense.
The 23 to 25 gauge needle used in an FNAC is so incredibly thin that the risk of tumor seeding is virtually eliminated.
And the ultrasound helps them guide it.
Right, the doctor uses an ultrasound screen to guide that microscopic needle precisely into the mass, draws out a tiny slurry of loose cells, and sends them to a pathologist,
The pathologist then categorizes those cells using the Milan criteria.
which is a very specific system.
Yeah, this isn't just a simple 1 to 6 scale. It is a mathematical probability index that dictates the violence of the upcoming surgery.
It ranges from category 1, which means non-diagnostic or insufficient cells.
All the way to category 6.
Yes, which is a definitive malignant diagnosis carrying a greater than 90% risk of cancer.
Now, if the tumor is larger than 3 centimeters, or if the Milan criteria indicates a high risk of malignancy, the diagnostic imaging escalates to an MRI.
Right, and the MRI looks for the structural fingerprints of cancer.
Like what specifically?
Things like irregular fuzzy margins instead of smooth ones.
Like the tumor's reaching out.
Exactly. Also destruction of the surrounding jawbone, and a terrifying phenomenon called perineural invasion.
Perineural invasion.
It means the cancer actively seeks out the neural pathways.
Visualizing that is chilling. It's cancer cells physically crawling along the outside sheath of the nerve, wrapping around it like ivy, suffocating a telephone pole.
Once that detective work is complete, and the surgeon knows exactly what kind of threat is sitting in the parotid gland, we enter the surgical minefield itself.
How do they actually diffuse the bomb and save the smile?
Carefully. Very carefully.
According to the clinical notes, there is one absolute golden rule before the first incision is ever made,
Do not use long-acting muscle relaxants during the administration of anesthesia.
which runs contrary to normal surgical logic.
It really does. Usually an anesthesiologist wants the patient profoundly paralyzed, so there is no involuntary movement while the surgeon works.
You want them perfectly still.
Exactly.
But in the parotid, it's like trying to steal a diamond from a room crisscrossed with invisible security lasers.
That's a great way to put it.
If you shut down the entire security system, you have no idea if you've tripped a wire until it's far too late. The surgeon actually wants the alarms armed and active.
Yes. They use a device called a facial nerve monitor.
How does that work in practice?
Well, if the surgical instrument gets even a millimeter too close to the facial nerve trunk, the electrical proximity triggers the nerve, and the sleeping patient's face will subtly twitch.
Oh, wow.
That real-time physical feedback is the only way the surgeon knows they're flying too close to the sun.
So if a long-acting muscle relaxant is in the patient's system, the face cannot twitch.
The alarm is silenced,
And the surgeon is navigating entirely blind.
which is unacceptable in this area. They also rely on rigid, universal geographical landmarks to find the nerve safely before it branches out into the face.
The anatomy has strict rules, but the margins are terrifyingly small. If you're listening right now, take your finger and touch the tiny piece of cartilage sticking out right in front of your ear canal.
Right, that little bump.
That is the tragal pointer. The notes state the main trunk of the facial nerve is reliably located exactly 1 centimeter deep and slightly inferior to that pointer.
Just think about that. Less than half an inch beneath your finger sits the biological wiring for your entire smile,
The second landmark is the tympanomastoid suture.
which is a specific groove in the skull bone just behind the ear.
The nerve is exactly 6 to 8 millimeters deep to that suture. A slip of 9 millimeters means irreversible facial paralysis.
Just virtually zero room for error. Surgeons also use the local blood vessels as a map.
The retromandibular vein is the crucial radiological landmark here.
Right, in the parotid region, the anatomy almost always follows a strict NVA arrangement.
Nerve, vein, artery.
From the outside of the face looking inward, the layers are consistently the nerve laterally, the vein in the middle, and the artery sitting medially.
So surgically, once you identify the vein, you mathematically know the nerve has to be sitting superficial to it.
It gives them a reliable roadmap. Now, the scale of the actual surgery depends entirely on what the FNAC and MRI revealed,
For a small, mobile, benign tumor, they might perform extracapsular dissection, or ECD.
which involves making a small incision and delicately peeling the tumor out of the gland tissue without removing the entire parotid.
But if the pathology confirms an aggressive malignancy, particularly a type called adenoid cystic carcinoma, or ADCC,
The approach shifts to devastatingly radical measures.
ADCC is notorious in the medical notes for something called skip lesions.
Skip lesions are a nightmare to track.
Because the cancer doesn't just grow outward in a predictable sphere, right?
No, it acts like a parasite. It travels inside the sheath of the nerves and essentially skips along the biological wire.
So a surgeon might cut out the tumor and find healthy, clear tissue immediately next to it, completely unaware that the cancer has already traveled 2 centimeters down the nerve line.
Exactly. To combat that cell, surgeons are forced into an extended radical parotidectomy.
Just to have any hope of curing the cancer, they often have to sacrifice massive amounts of collateral tissue
They will intentionally remove the overlying skin, portions of the jawbone, the ear canal.
and purposefully sever the facial nerves.
Yes, they save the patient's life, but the trauma to the facial architecture is profound.
And even in the best case scenario, say a perfectly executed surgery on a benign tumor where the nerve is completely preserved, the biological aftermath can be bizarre.
Right, as that complex neural web tries to heal itself in the dark, you see dramatic physiological misfires,
The most documented example in the notes is Frey's syndrome.
otherwise known as auriculotemporal syndrome.
The mechanics of this are mind-bending. When the surgeon removes part of the parotid gland, they have to snip the tiny autonomic nerves that used to plug into it
And those specific nerves had one single job.
to tell the parotid gland to produce saliva when you chew food.
But severed nerves desperately want to heal. They send out new biological shoots, searching for something, anything to connect to.
As the surgical bed in the cheek heals, those Those tiny saliva-producing nerve endings grow outward toward the skin.
And they mistakenly plug themselves into the sweat glands on the patient's cheek.
The physical wires literally get crossed.
It's a fascinating misfire. The next time the patient sits down to eat a meal, the brain sends the usual signal: produce saliva.
But the signal travels down the crossed wire into the skin.
So the patient begins profusely sweating down the side of their face every single time they take a bite of food.
It isn't physically dangerous, but the notes emphasize how socially and psychologically agonizing it is for the patient.
You can imagine how uncomfortable that would be in public. Another physical complication is a salivary fistula,
Where the remaining portion of the parotid gland continues pumping out saliva.
but the fluid leaks directly through the healing surgical wound on the side of the neck.
The treatment for both the crossed wires of Frey's syndrome and the leaking fistula is astonishing, actually.
Yeah, the medical notes prescribe targeted injections of Botox.
We culturally associate Botox purely with cosmetic wrinkle reduction,
Right, smoothing out the forehead.
but its biological mechanism is profound. It is a potent neurotoxin that acts as chemical scissors.
The doctors inject exactly 2.4 IU of Botox into multiple sites across the cheek.
And it chemically severs the communication between the nerve and the sweat gland or salivary tissue by blocking the neurotransmitters.
It is a highly elegant, temporary mechanical fix for a deeply frustrating physiological misfire.
But those are the complications when the nerve survives. If the surgeon was forced to sacrifice the facial nerve to eradicate a cancer,
The medical notes detail the arduous reality of facial reanimation.
reanimation focuses on giving the patient back some semblance of function and dignity. It's broken down into static and dynamic procedures.
A static procedure doesn't restore movement, but it fixes a critical mechanical failure,
For instance, if the nerve is severed, the patient cannot close their eye.
which quickly leads to corneal scarring and blindness.
Right. So the surgeon will literally embed a tiny, precisely weighed gold implant inside the patient's upper eyelid.
Because the muscle cannot receive the electrical signal to blink, the physical weight of the gold allows gravity to pull the eyelid shut whenever the patient simply relaxes their face.
That is incredibly ingenious.
It is. Now, dynamic procedures attempt to restore actual physical movement to the smile.
How do they do that if the nerve is gone?
Surgeons will transplant entirely different muscles to do the job of the dead facial muscles.
Oh, wow.
They might detach part of the masseter or temporalis, the heavy muscles you use to clench your jaw, and physically stitch them to the corner of the mouth.
That's incredible.
Or they perform a free nerve muscle transfer, harvesting a piece of the gracilis muscle from the leg, along with its blood supply, and wiring it into the face.
But the timeline for these dynamic procedures requires monumental patience.
It really does. Peripheral nerves grow at an agonizingly slow rate.
Roughly 1 millimeter per day.
The notes clearly outline this grueling timeline. Surgeons use an EMG and electromyogram to monitor the transplanted muscle tissue.
And they don't even see the first microscopic electrical flutters of reinnervation until 4 to 5 months after the surgery.
That is nearly half a year of the patient waiting, completely paralyzed on one side, just wondering if the surgery worked.
And achieving final maximal function of that new muscle takes up to 2 full years.
It tests the absolute limits of human resilience.
So mapping out this entire clinical journey,
Mhm.
we've looked at the foundational chemistry of a gland pumping out huge volumes of water and enzymes.
We've seen how rogue calcium phosphate stones and autoimmune attacks can break the plumbing.
We've explored the intense detective work of the Milan criteria, allowing doctors to gauge the risk of tumor spillage.
And we've navigated the millimeter-perfect anatomical geography required to extract a lethal threat while fighting to preserve the delicate cranial nerves.
It is the ultimate collision of raw biological mechanics and high-stakes risk management.
Absolutely.
As we wrap up this deep dive, there is a profound psychological undercurrent to all these clinical notes, these NDA arrangements and surgical margins, that is worth sitting with.
Yeah, the human element behind all the science.
Right, our facial expressions are arguably the most fundamental way we project our humanity to the world. A subtle shift in the cheek or the eye is how we communicate empathy, joy, surprise, and love without ever making a sound.
It is the physical manifestation of who we are.
Imagine the internal calculus a patient must perform when facing a parotid tumor. How does the terror of permanently losing the physical ability to smile or to blink alter how they weigh the risks of the surgery itself?
It has to be overwhelming.
When the procedure designed to save your life might permanently erase the expressions that make you recognizable to your own family, it is a stark reminder that in head and neck medicine, eradicating the disease is only half the battle.
Preserving the patient's identity, their humanity, is the true ultimate goal.
A heavy, essential perspective to keep in mind. Thank you for joining us on this deep dive. Till next time.